going to upload it onto the training website at some point when I get a chance. So, circulatory problems, cardiovascular system. What we're going to do is we're going to go through a recap on the functions of the cardiovascular system. We're going to talk about the anatomy and physiology of the heart, blood vessels, what it does. Then we're going to relate it to the common conditions. So we're going to talk about coronary artery disease. We're going to talk about stable angina. We're going to talk about acute coronary syndrome. And then finally a little bit about heart failure. And that is just a bit of extra, really. There's not much we can do pre-hospitally about it, but it's good to know what is going on with your heart failure patients. So what is the cardiovascular system? Let's put some answers in the chat bar. Let's get involved. What is the cardiovascular system? What are the three main functions of it? So, carries oxygen, nutrients around the body, yeah, good. Pumps blood all around the body, yeah. Oxygenation, good. So lungs are part of our cardiovascular system a little bit. Transport, oxygen, glucose, etc., good. Pumping system, yeah, carries waste products out, good. Removes the waste, excellent. So we've got number one, which is transport of oxygen, carbon dioxide, nutrients, the wastes and the good stuff. What else does the cardiovascular system do? Which are the main functions? So we know transport is a key thing it does. Anything else? Yeah, good. Regulation of the body temperature. So if we get too hot or too cold, then our cardiovascular system reacts to that, either dilation or constriction of those outer peripherals. Good. So regulation of the body temperature. And then one other thing that it helps with. We talked about in our CPD this year. White blood cells, yeah, so it's a part of our immune system, good. Hormone control, maintains blood pressure, good. And don't forget about the clotting factors. So it will help with clotting and stop any kind of external hemorrhage or wounds or bleeding. So clotting is a really important part of our cardiovascular system. So at the most basic level, the cardiovascular system is composed of blood vessels that transport blood around the body, and that is thanks to the heart, which works as the pump. It's composed of the heart, arteries, capillaries, veins, and then lungs play a part in it as well. So different types of blood vessels. Again, let's go through the basics. They're all made up of different layers, so they've got different kind of structures and different. The lumen is thicker and small in some blood vessels. So we've got the artery, we've got capillaries, and we've got the veins. And like I said, all the vessels structured wise are differently. So capillaries are based with a single cell wall layer, because we know the capillaries allow the oxygen gas exchange. So when did we talk about it? We talked about the respiratory system last time. We talked about the alveoli being coated around with that capillary layer. It's a single cell which allows that gas exchange. Our arteries are going to be a little bit tougher, a little bit more flexible, because they need to cope with the high pressure blood flow. And we know if we cut one of our arteries, within minutes we can bleed out because they're under high pressure. So the arteries need to be a little bit tougher and a little bit more flexible. And then the veins have little valves in it. So you can see the little valve in that picture. because the blood is traveling at a lower pace. So the actual veins need valves to stop the blood flowing backwards. So they're the kind of three different blood vessels we've got, and the structures are all different because of the different tasks that they need to cope with. So what is blood then? Tell us the basics about blood. What is the blood made up of? What does it do? So it's made up of four main compounds. So what are those four main things that are in our blood? Keep the basics. We don't need too much. Yeah, plasma, good. So plasma is the kind of liquid side of the blood, which is the easiest way to talk about it. Platelets, yeah, good. So platelets will allow clotting and prevent further blood loss. What else have we got? Red blood cells, yeah, good. So red blood cells, as we know, transports all the oxygen. And then I think finally we got the last one, did we? One more. White blood cells, yeah, good. So that's our part of our immune system, and it fights all those infections. Excellent. So four main compounds are the red blood cells transporting oxygen, white, which is our immune system fighting all the infections, platelets that allow the clotting factors and clotting to take place to prevent any further blood loss, and then plasma is basics of the liquid side of the blood, but it does have other kind of tasks as well. Awesome, good. So heart. Anyone very good at the heart and want to talk about the heart? Any volunteers? Or do you just want me to talk? Pass. Good, okay. Good, anyway, it's going to be a catch-up. So, looking at the picture of the heart, let's talk about what's happening and what's going on with it. So, we have the deoxygenated blood entering through that supravena cava, going down into the right atrium, then it goes down into the right ventricle. That right ventricle then constricts, forcing blood out through that pulmonary vein up into the lungs to get oxygenated. Once it's oxygenated, then it's going to come back down through the pulmonary veins, back into the left atrium, down into the left ventricle, and then that left ventricle is going to constrict, forcing blood out of the aorta to the rest of the body. Nice and simple. Really good thing, really good piece of muscle, really. It's only, if you clench your fist, that is the size of your heart. So the muscle size of your heart is keeping you alive, and it's doing all of that. So it's a really good organ, and it does so much. So the basics of it is the right hand side deals with the deoxygenated blood, left hand side deals with the oxygenated blood, and that's what's happening. But for that to happen, we need to have a good old electrical system to coordinate it, because if the heart's just pumping all over, then we're not going to get that top chambers pumping down to the left chambers pumping either up to the heart or around the body. So we need an electrical pathway to the heart. So what's going on here? Our hearts have our SA node, which is our natural pacemaker. And as you can see in the diagram, it's in that top right kind of atrium up there. So that is our natural pacemaker, and that is what coordinates and allows us to have that irregular heartbeat and allows the heart to function properly. The next thing that we need to talk about is that AV node. AV node is the gatekeeper to the ventricles. So the SA node constricts the top chambers, and then the AV node will allow the bottom chambers. But we can't have the whole heart pumping together, because we need to pump that top one to go down to the bottom. So It will start with the SA node, which is our normal pacemaker. It will constrict the two top chambers, the left and right atrium. Then it will go to the AV node, which will be, the electrical activity will be held there for a millisecond, just to allow the top chambers to empty to go into the ventricles. Once the blood is down into the ventricles, our electrical activity will kind of flow down our bundle branches down into the apex of the heart. So from the AV node, it will travel down the septum down to the bundle branch, and then it will constrict the lower chambers, the ventricles. And it should look like that. And hopefully that video is playing for everyone. So the top chambers are constricted down into, held at the AV node for a millisecond. Then the bottom chambers will constrict, allowing the blood to go either up to the lungs or around the body. Everyone happy with the functions of the heart, where all the blood goes, and the electrical pathways, which allows it to happen. Cool. So you've all probably seen this when the crews do their ECG. So the electrical signals can be traced, and we can put the ECG on. So the electrocardiogram, the ECG. Two types that we can do the 3-lead, which is really 4 leads, the leads that go on the limbs, which gives a little glimpse at what the heart's doing. Then we can do a 12-lead ECG, which is more in depth, which allows us to see a kind of a 360 view of what's going on in the heart. So normal sinus rhythm is just what we've just seen. The heart is functioning good. The SA node's working, the AV node is working, and the heart is pumping correctly. So you will probably see it hopefully more than any other ones. So you've got the kind of PQRS complex, and that just shows the heart is the P is the kind of atrium, then the QRST is the ventricles, and then the T wave is everything relaxing again. And that is what is happening in the heart, and it just shows the electrical pathways is working correctly. When there's a damage to the heart, so if the patient had a previous MI, then it means there's ischemia in the heart, and that part of the heart has died, which means the electrical pathways can't go along. So if we think down at the apex of the heart, if the right side of the bundle branch part of the heart has died, the electrical activity won't go past the dead part of that muscle. So it has to go a different way around it, and that is what's shown up on the ECG. So if it can't go the normal pathway it should, then that PQRS complex will be different. And that's what we can identify when there's an arrhythmia or there's a problem with the SA node or the AV node. And that's what the ECG does. Really good. So one of the common conditions you probably come across is AF. We know AF is when we take a pulse and it's irregular. Why is it irregular? The reason for it is the SA node is failing. So the natural pacemaker isn't working, and the actual pacemaker is happening somewhere in those atriums. So normal sinus is that picture on the left. AF is the one on the right. So the SA node isn't really working, and the actual pacing site is happening somewhere in the atrium, which means you have irregular heartbeat. And that's kind of what's happening. It's either it can go too fast, too slow, or it's just irregular and you have a misspeak. So the SA node may work 6 times, and then somewhere else in the atrium will kick off, and then that's where you have that skipped beat, because the SA node's failed, and somewhere else in the atrium it's triggered off the pacemaker. So that's what's happening in AF. But it shouldn't affect the kind of ventricles. So that's why people can live with AF, because it's only affecting the atrium. If that was affecting the ventricles, then that would affect the blood flow to the lungs and the heart. So that's why people are medicated and live quite well with it. Will AF affect blood pressure? It can affect blood pressure, yeah, for sure, because if it's going too quickly, if that pacemaker's failed and it's got fast AF, so fast AF could be anything from 100 to 150, because that SA node is failing to pacemake it, and there's firing going on in the AV, in the atriums really quickly, which means the heart won't be able to function efficiently. So that's when they have to have the beta blockers to slow things down and slow those atriums. And if that was happening, if it was affecting the heart or the blood pressure, then that's when they would probably have a pacemaker or something fitted. But it is well controlled with medication. So the heart itself has its own blood supply, because the heart is a pump, and it's a muscle, and we know all of our muscles need a blood supply. So the actual heart has three kind of main coronary arteries. It's got the right coronary artery, the left, and then the anterior that kind of goes around to the apex of the heart. And we'll talk about the importance of that blood supply when we talk about ACS, acute coronary syndrome. So that's really important to know the heart has its own blood supply, because it is a strong muscle. And if we disrupt that blood supply, then the muscle is going to fail. So that is all on the kind of anatomy side of it. Everyone happy or got any questions about the anatomy side of the heart? Please don't make hard questions, but it's just the basics that you need to know. Everyone happy? If you have got a hard question, that's fine. I got Google up on this other screen, and we can Google it. Cool, excellent. So let's go on then. Coronary artery disease. What is the coronary artery disease then? Anyone know? We know where the coronary arteries are now. You've got three of them, which we just spoke about. What is coronary artery disease? Blockage, okay. When the arteries get clogged up. Yeah, good. So it's that build-up of plaque, it's build-up of that lipids, fatty, cholesterol, hardening of those arteries. Yeah, good. Okay, cool. Aneurysm, not so, sort of. It wouldn't be in the coronary, but yeah, if you had it elsewhere, so you can have a aortic aneurysm, which is, it's not really the thickening of it, it's the kind of when it gets a little bit looser and it bulges out, and then when we have a ruptured aortic aneurysm, that's when it kind of breaks. But cool. Arteriosclerosis, I can't really say it, but it is arteriosclerosis of the coronary artery disease. So that is the symptomatic kind of lipid fat, which is driven by the immune system and the inflammatory disease, and it affects our medium to large arteries, which is normally the left, right, and the of the coronary arteries. So it happens over decades. So coronary artery isn't just a sudden thing that you can have, it is through lifestyle. So if you have got poor diet or poor overall lifestyle without exercise, then it will build up. And they say most people, once you get to kind of 65 and over, they have got some form of coronary artery disease, some form of thickening of their arteries. But it what's important to note, it is over decades. So this is not an acute thing, it's a lifestyle thing. So if that plaque and the lumen kind of thicken, so the lumen is that inner part of the arteries, and you get it in at the arteries and in some thick veins. So if that thickens, then that narrows the artery. When we narrow the artery, that can lead to cardiac ischemia, so the kind of death or the damage to the actual muscle of the heart because of the reduced kind of oxygen going through at high demand when the patient or when the person's got high demand. So during exercise, when you're walking up and down the stairs, your heart has to work a little bit harder. If we've got narrowing or thickening of our arteries, it can't get through and it's reduced, and the other side of that thickening, that part of the muscle will get some sort of ischemia because it's not getting enough oxygen at that time of exercise. And it can lead to the plaque rupturing and coming apart, and then that can cause blockage and can lead to acute coronary syndrome. So it's not great. So we're going to talk about the kind of effects of it now. So looking at it in a picture wise, remember this is over decades. So this is a picture of an artery, and we've got cholesterol kind of building, plaque and lipid kind of fat building up. It will build up until we've got a narrowing of that artery. Let's think we're walking up the stairs, we have to work a little bit harder. Our heart is pumping faster to get more blood, and with that narrowing, we're not going to get enough blood through, which is going to cause a little bit of a hypoxic response and a bit of ischemia distally to this blockage or this narrowing. It can lead to angina, and it can lead to acute coronary syndrome. This is another little diagram of it. You've got your normal arteries at the top, blood coming through, and then we've got our abnormal arteries with that plaque buildup and the narrowing of the artery, and those coronary arteries where it will happen. So our left and right coronary artery and our inferior artery going around to the apex of the heart. Cool, everyone happy with that? So that is coronary artery disease. To be honest, pre-hospitally, you're not really going to come across it, but if they tell you they've got it, then you have to have kind of a awareness of possible angina or ACS problems. What's the usual meds? Normally statins. So it's all about controlling lifestyle. They're going to tell you to do a little bit more exercise. If you've got high cholesterol, they're going to give you a statin to sort that out. But normally it is diet, exercise, and yeah, statins are kind of the normal way of doing it. Cool. Yeah, like I said, you've got higher risk of angina and ACS, so it's really important when you do your history take, if they've got chest pain, if they've got a history of coronary artery disease, then they're in a higher risk factor of having something serious or an acute episode or something. So, stable angina then. What is stable angina? Or what's angina? Short term, okay, yeah. Pain across the chest, type pain across the chest. Only comes on with exercise, good, which is stable, okay, yeah, good. Reversible with GTN, yeah. Pain down an arm, yeah, good. Temporary, reversible, restriction of the coronary blood flow, yeah, good. And exercise induced. Cool, good. So yes, it is linked to the coronary artery disease, so it is really common if they've got that. Most likely they've got angina. Angina, main symptom of it is going to be the chest pain due to the narrowing of those coronary artery diseases. So stable means it normally comes on with exercise or other kind of triggers. So we know exercise is a trigger. Anyone know any other triggers of angina? Yeah, good. Yeah, stress, anxiety. Stress is a big one at the moment with COVID and everything going on. Yeah, emotional stress, heavy lifting. Yeah, again, that would be kind of falling under exercise. Good. So yeah, the main two ones there are exercise and stress. Don't underestimate stress because it may be someone in an office worker. You go in, they've got angina or chest pain, and they haven't been exercising, but they've had a stressful meeting, and stress can induce angina as well. So stable angina is the most common form of it, and it is normally down to a trigger, either stress or exercise, but there are some others, but it will stop within minutes or within a few minutes with rest. So if you, I think the timing now is like 15 minutes. If it doesn't ease within 15 minutes of rest, then we're more thinking about unstable and ACS kind of symptoms, but it should. And I think Mark was talking about, Mark talked about GTN as well. So with medication, GTN will ease it as well. So the actual symptoms of it are, we're going to have the trigger of it, either physical exertion or stress. They're going to have the most common kind of symptom would be pain and discomfort, down to the severe narrowing of those coronary arteries that we talked about, reducing the demand of oxygen distally to that blockage, and that is what's causing the ischemia and the pain. Exertion's normally walking up a hill where your heart has to work a little bit harder, or stress where your heart is working a little bit harder. Cool, I think, Nick did mention temperature. I believe I saw it somewhere. Someone mentioned temperature. So yeah, sudden exposure to temperature can cause it, either very hot or very cold, most likely very cold here, and heavy meals as well. So Sunday, we're in a hot restaurant, Sunday afternoon, they've had a big meal, really hot, they've either fainted or they've got chest pain, and most likely it's stable angina, and as long as you cool them down, rest them, then the pain should ease. And smoking's more of a cause of coronary artery disease than angina. So signs and symptoms, you've mentioned it, the typical tight chest, someone sitting on the chest, central chest pain. It can radiate to the jaw, neck, down the arms, into their upper abdomen. They will be pale, cold, clammy. They may feel short of breath. They will have anxiety, and it will kind of ease, or usually occurs with exertion or stress, and it should go away with rest. Other treatment for it would be GTN, but I think we're going on to treatment now. Cool. So your treatment for it is you're going to sit them down, encourage them to rest, reassure them. It's what you guys are really good at. Let them use their own medication, to GTN or nitrates. Anyone know what GTN does? Yeah, good. Widens the arteries. It's a vasodilator and it expands those blood vessels. Good. So we know what's going on in the heart. We know there's a little bit of constriction, blood flow because of the buildup of plaque. So by giving GTN, we're going to dilate that blockage, allowing more blood flow to go through to ease the pain, to ease the ischemia, and it will stop the pain, hopefully. What is important is it's not just going to affect that one bit of the heart, it's going to affect all of the blood vessels. So if they're standing up, they may feel faint, or if they take multiple sprays, they will probably faint in the end, because it is going to dilate all their blood vessels, their blood pressure is going to drop. So if they are going to take it, make sure they're sat down or in comfortable position, and make sure they don't take more than 2 sprays initially. So they can take 2 sprays, and then 5-10 minutes later, no effect, they can take another 2 sprays. After 15 minutes, we're going to be treating it as ACS anyway. Yeah, often a headache. Again, that is due to expanding of that blood vessels, reducing blood flow to the heart, to the head, which gives them that headache. But again, that will ease because the effects of GTN doesn't last that long. But yeah, headache is often common for these patients. Oxygen if indicated. So just follow your oxygen guidelines. Below 94, then we can give them some supplementary oxygen. But routinely, it shouldn't affect their lungs, so it shouldn't cause them to be hypoxic. And then, yeah, if it goes over 15 minutes, suspect it to be ACS pain. Cool. Everyone happy with stable angina? Good. Oh, yeah, record observations, prepare to resus if you're expecting it to ACS. If it's just normal angina and it's getting better, please don't put a defib and get defibs out, because that's not going to be very reassuring to that patient. But if you're considering it as ACS, then we should be prepared. So Viagra, to be honest, I don't think in pre-hospital kind of an emergency it would, but it's their own medication. So we don't really need, if it's their own medication, we don't really need to be worried about contraindications to it. But there are some contraindications that we follow. But for the patient, keep it simple. If it's their medication, their GP should know their contraindications to it, so they can just take their own medication as normal. That's why we don't give, you wouldn't give someone else's G10 to a patient. So it has to be their medication because of that reason of contraindications. Cool, so acute coronary syndrome. We should know this now. So what is acute coronary syndrome? What are the 2 main conditions that would fall into this? Yeah, so it would be unstable angina and MI. Yeah, good. So stable angina is the less severe one, and it will ease with rest, where unstable angina and a myocardial infarction or heart attack, that will fall within ACS, because we know it hasn't gone away in 15 minutes, so it's going to be a little bit more acute. There may be a blockage, complete blockage going on there. So 3 things there is, yeah, unstable angina, non-STEMI elevation, myocardial infarction, and then a ST kind of STEMI myocardial infarction. That just means where the blockage is and if we can see it on the ECG. So on that little picture, you can see the normal PQRS complex. So that line should be down the bottom, but because there's a ischemia and there's a blockage of part of the heart, the electrical activity can't get down to the lower part of the apex of the heart, so it bypasses it and goes down. So that's what you can see on the ECG. It can't get down to the bottom part, and that's why it's elevated, because there's a damage to the heart and the electrical activity is not getting to it. And that's why it's so good to have an ECG. Non-STEMI just means there's no elevation to it. So sometimes you won't see the blockage through the electrical activity. That's why they have to go and have bloods to look at enzymes and see if there's damage to the heart that way. So normally patients with diabetes, unfortunately, it's more common in females. Don't know why, but it is. But yeah, females and people with diabetes normally will have a non-STEMI where you don't see the elevation in the ECG, or commonly known as heart attack. So, pathophysiology, what's going on? We've got those 3 coronary arteries that look after our heart. We know the heart is a muscle, it needs blood supply. So if we've got a bit of that plaque or something else, a embolism, come into one of those coronary arteries and block it, then we're going to have an MI or unstable angina. So if they've got coronary artery disease, we know they've got a higher risk of it. So we've got plaque or cholesterol built up in that artery, narrowing that artery. So if we have a thrombus or a blood clot, so it may be part of the plaque has come away and blocked the artery, or it might be a pulmonary embolism, which is come from another part of the body. That will come along and it will get stuck in this narrow part of the artery. That blockage then will cause a complete blockage to the coronary artery. And we know we've only got 3 of them. So if we block one of them, we know at least one part of the heart is going to not get any oxygenated blood to it. So depending where it is, you've got that little yellow dot at the bottom. So if we've got a blockage down the kind of the apex of the heart, then it's going to be a little bit less, it's still going to be severe, but a little bit less severe because it's only going to affect the lower part of the heart. So you're going to see a little bit, that may be someone with chest pain, and they may have chest pain for a while. If we move it a little bit, so if we have a blockage right at the top, then we lose the whole kind of ventricle, which pumps blood around the body. So that would be more fatal probably. That blockage that high, then the blood isn't going to be pumped around the body. So that would more lead to probably a cardiac arrest quite quickly, whereas the previous one would be more chest pain. So silent MI when there's no chest pain, which would be that non-STEMI, again females and diabetic patients are more likely to have silent MIs. Cool. So yeah, there are the blockages, and it depends where it is, depending the severity of the myocardial infarction. So if it's really high, blocking the blood supply to the whole ventricle, then most likely it's going to be a cardiac arrest. Anything else, a little bit lower, it would be quite severe chest pain because the heart is still not functioning properly, it's not pumping properly, but it's still able to have some sort of function to it. So signs and symptoms, very similar to stable angina. They're going to have chest pain, a little bit more severe maybe, crushing. So they normally say it's like someone sat on their chest. Pain radiates again to the arms, jaw, neck, upper abdo. Yeah, short of breath. Sweating. Sweating's a big key one. They're going to be dripping wet, but again, depending on where in the heart it's affected. They will be pale because their actual pumping and blood supply to the body is going to be reduced. They're going to feel cold. Nausea and vomiting is quite common. Short of breath. And then in some cases, yeah, elderly, diabetics, they may have no pain and called silent myocardial infarction. Why it's important, pain will not go away with rest or medication. So if you've given them a GTN, it's been 15 minutes, then we're going to go down the ACS route. and it can occur at any time, so with rest. So your key history is I've woken up, severe chest pain, or the chest pain has woken me up. That is red flags for you. Yeah, can be mistaken for indigestion as well. So treatment, same as before, we're going to reassure them. We're going to sit them down, make them comfortable. W position is what the textbooks say because it eases the stress on the heart. But just put your patient in the best position for them. If it's going to stress them out, getting them on the floor and legs, then just make them comfortable. But if you think they're going to go into an arrest, then it's better for them to be on the floor. Oxygen if required. Again, go down your oxygen guidelines. We don't give it routinely because oxygen does have an effect of vasoconstriction. So if they've got constricted or blockage and we're constricting their blood vessels even further, then that's not really helping that patient. So only give it if they're hypoxic. Monitor the patient, help them take their own medication if they need, and then prepare to resusc. Cool. ICDs then. So ICDs or pacemakers, same thing now. Really small little internal defib that is placed in the heart. So if they've had a previous MI and there's a damage to the heart or damage to that SA node, or the SA node or AV node not working, which is not allowing them to regulate the heart rate, then they're normally fitted with an ICD. It is a battery powered defib, normally lasts about 10 years and then it has to get changed. It monitors, there's different ones, so it can monitor the heart constantly or it'll kick in when it needs to. But it looks out for the life-threatening arrhythmias, so VT or VF, when the atrium pacemaker's failed and the ventricle kind of is pacemaking it and it's going too quickly. When it goes too quickly, the heart can't fill with blood, so it's not pumping blood effectively. If they identify that, it can deliver a small shock directly into the heart to pacemake it. So again, two types. A pacemaker will deliver a impulse to it to pace it, to slow it down. An internal defib will shock it to stop the heart to try and restart it back into a normal rhythm. So they're the two different types. Pacing will pace it and you'll see a pacing spike on the ECG, and an internal defib will identify VF or VT and it will shock it to stop it to allow the natural pacemaker to kick in again. Yeah, and it's, what did it say? Bradycardia as well. So if it's going too slow again, that pacemaker will kick in to speed it up again. Really good bit of kit. So who would have it? Anyone with a life-threatening arrhythmia. So they've got history of VT, VF when it goes too quickly, they'll have one. Any patients who has potentially been resuscitated from a cardiac arrest, again, that'll be down to arrhythmia at the top that's caused that cardiac arrest. Certain patients with a high risk of developing these emergencies, and again, ICDs can be paced both to adults and children. The only thing you need to identify is if they've got one, try and avoid putting the defib pads on directly on top of it. Normally you'll see a little scar and it's a tiny scar. And if you do, just avoid putting it on. So think when we're putting the pads on, we're drawing that line through the heart. So if you can't do it in the normal routine spot, you can go under the arms or front to back, as long as you can draw that imaginary line through the heart so the electrical activity goes through it. Finally, we're going to talk about heart failure. Again, this is from what we've just talked about. So if they've had coronary artery disease, if they've had a ACS episode that's damaged the heart, then normally they'll have heart failure through that. So heart failure is the abnormality of the cardiac structure or function, leading to the heart reduced ability to deliver oxygen and nutrients around the body when it's needed. So patients with a history of ACS or the damage to the heart will normally have heart failure, and if the patient has signs and symptoms of it and they haven't changed in the past month, then it can be considered as stable heart failure, and then you can have unstable if it is not controlled. And there's the picture of it. So you've got normal heart, then you've got the heart failure. So most likely this person's had an MI, which has damaged that kind of left ventricle part of the muscle, and it's kind of enlarged that ventricle. Or it's had an MI somewhere else, which has pulled the blood down in the ventricle, not allowing it, which has stretched it. So it's just the function of the heart has, or the structure of the heart has changed, which has led to the heart failure. Very difficult to assess in the pre-hospital environment, but we put it in just so you kind of can understand if they've got heart failure, most likely they've had ACS or an MI or unstable angina in the first place. So they've got good cardiac history that's caused it. Common signs for it if you go in to see it. Anyone know what that is? Big words. Everyone loves big words. No, have a guess. Yeah, cool, good. Nighttime, not breathing. Yeah, cool. Not breathing right at night. So they can't sleep. They can't lay flat. If they lay flat, they become breathless. Good. They may have cough. Again, this is if they had unstable heart failure, they would have this, and they'll be bringing up kind of pink phlegm with bits of blood in it. Main reason for that is most likely the heart isn't functioning and more blood is going up to the lungs and it's not coming back down. So when they're coughing, they're bringing blood up as well, because the heart isn't pumping effectively. We're getting a pooling of blood up at the lungs when it's being oxygenated. Next thing there would be, and the most common thing you will see is the peripheral edema, the swelling of the ankles, or pitting edema. So if they've got big ankles, give it a little poke, and if you see pitting edema and you put your finger in and you pull it away and your finger indent is still there, again, that's just showing the heart isn't pumping effectively and blood or fluid is pooling at the lower limbs. And that's the main one that you'll see there. Management of it, not really much you can do. Often it's just about assisting their breathing, sitting them upright, and then doing your ABCD approach and identify it. They may need oxygen because, again, their heart isn't pumping effectively. You may get a buildup of fluid in the lungs, which is causing hypoxia. So look at your oxygen guidelines. They may need some oxygen if they are hypoxic. Should have a little question mark there. Awesome. So any questions or anything on cardiac system, or you're happy as a little recap with that? I'm going to stop the recording.